The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Yeah, my name is Sue Cantor and I'm from Adelaide, and I feel compelled after this morning's session to declare that I am a South Australian and I have had an arthroscopy. And unfortunately it did turn out to be for osteoarthritis, so I'm damned before I even start. But this is the lovely Royal Adelaide Hospital for about the next 4 weeks. As you may know, we're shortly to move to the most expensive hospital that's ever been built in the world. But what we have at the moment is, as you can see, what a lot of hospitals are in Australia and in fact the world over, which is they're a combination of old, new and God knows what, and they bring their own issues. In my talk today, I'd also like to acknowledge my colleagues in the Sim Centre. Obviously, I don't work as one person. There are 4 of us that work in there, and this is a collaborative thing, so I'd like to say thank you to them. And hopefully I can make this work. Okay, so simulation training has really become a cornerstone of education. And it doesn't really matter where you are or what industry you're in, you'll find evidence of where simulation training is used. And there's been quite a lot of cross-pollination from aviation and from defence into health. And I think most people would recognise that simulation training offers a lot of benefits. And probably the best benefit for health is that it's actually very safe for the patient. So what we offer people is an opportunity to practice skills, whether they be technical skills or non-technical skills, in an environment where we try to create fidelity based around what they're actually doing in real life, but we take away the risk of actually killing the patient. And in fact, when we finish our MER training sessions, the most common comment we get is, "Oh my God, we didn't kill the patient." Which generally most people see as a positive thing. So at the Royal Adelaide we're fortunate to have 2 simulation centres. So one of them is based in anaesthesia, and I've worked there briefly before. And there's a second simulation area in fact, the old intensive care building, which was sort of modified for our purpose when ICU outgrew that space. And the list here is really... this is sort of the core business of what we do in simulation, but it is not an exclusive list. So actually we find ourselves doing lots of things in addition to this. So people will come up and say, "We want to do this, can you help us?" And generally we'll try and do that. But essentially our core business is we do MET simulation team training, we do ICU team training, we teach airway skills, both basic and advanced. We do BLS and ALS reassessments for both ICU and cardiology. And we also help with the renal course in offering a simulation session for their patients and staff that work in outreach centres, looking at what they do with their patients. So I've said here study objectives, but probably a more accurate thing would be a review. So what we did was every time we run a simulation, we try and collect feedback from the participants, which is about trying to improve the educational experience for people that come after. So we ask them, you know, did they like it? Did they think it was valuable? Did they learn something useful? And then we sort of ask them at the end to give us like a take-home message. If there's one thing that they're going to take from this experience, what would it be? And we tend to sort of guide that through our debrief. And so we see that as important because that's the actual people doing the education who are telling you whether or not it's actually met their needs. Because it's okay for me to design a program and say this is what you need, but actually if it's not what you need, then actually it's still not any good, is it really? So we've focused on those people and said, tell us what you think it is you need. Are we meeting those needs? What do we need to change to actually make this a better experience for you? So what we did was we decided we would look at a single group. And the group that we chose was the MER Team Training. What my colleagues have spoken about here today, obviously at the Royal Adelaide we have a 2-tier MET system. So we have a Deteriorating Patient call, and then we have a Code Blue call. And we have slightly different levels of response to that. In the lower level Deteriorating Patient call, we do not have an ICU doctor attend. Basically we have thousands of calls a year, and the ICU doctors felt that it was too much of an impost on their time away from the patients in ICU. So the lower level team is run essentially by the medical and surgical services. and it compromises of 2 RMOs, 2 interns, you get 1 ICU nurse, and then generally you get ward staff to help you. And so when we do our MER Team Training, we assemble that team. So we actually get RMOs, interns and ICU nurses that are part of the everyday MER team, and we put them together and we give them clinical scenarios. And so what we did was said, let's look at these people. We evaluated them over a year, and we looked at the comments that they gave us and said, what is it these people are saying that they need? And I'll go through how we actually categorised it a bit more. So this was how we collected our data. So basically, at the end of, in each MET simulation, they run for an hour. And what we do is we run 2 scenarios with each group. And the reason that we run 2 scenarios is because previous feedback has told us that people always want to do better. So what happens is generally in the first scenario, the people that meet don't know each other. They may have met previously, but generally they're a bunch of strangers. It takes them a while to work out what the personalities are like, who's more dominant, who's not dominant, who speaks out, who doesn't speak out, who's got this skill, who's got that skill. And so often they'll come out of the first scenario for a debrief and they'll be, oh, we could have done this better, we could have done that better. If we end the scenario there, they go away feeling disappointed. So what we do is we give them a second scenario, totally different, and they feel like that because they've got their shit together as a team, that actually they're going to be better. And generally they are. We have to be fair and say that. So what we do is we have a session, we run a scenario, we have a debrief, we run a scenario, we have a debrief. And then during the debrief is guided by the facilitators, of which there's usually 1 member of staff from the simulation centre, which is generally a registered nurse, usually from ICU. And we have the medical facilitator, who's an advanced trainee, usually in medicine. And they sort of coordinate the programme, they allocate the doctors to attend. And then what we do is we sit down and we talk about, you know, what went well, what was terrible, how did people feel about it. And then we ask them, you know, what's your take-home message? What have you got out of this? And so you can see here, these are some of the take-home messages that we got. And so people talk about things like, you know, when you give a medication order, it's really important that you tell the nurse the drug, the dose, and how you want it given. And usually, I don't know what your met calls are like, but it's like, can we give some salbutamol? You're like, yeah, we can. How much do you want? And it's like, oh, yeah, how do you want it given? Oh, yeah, you want it given like that. Do you want it right now, or do you want to wait 5 minutes? So it's important that people tell you what's going on so they don't waste time. And people talked about, you know, what do I do if I see something being done incorrectly? You know, can I speak out? As an intern, can I tell my RMO that actually I don't think that's right? So what we did was we looked at all of the comments from 2016. So in 2016, we provided 59 multidisciplinary MET sessions. We had 373 participants, and we got 220 comments. And of those comments, we defined 130 of them being related to non-technical skills and 90 of them being identified as technical skills. So then what we did was we said, well, we're not really interested in technical skills because we do a lot of education around technical skills, but we're really interested in what the non-technical skills are. And so what we did was we looked at every single comment that we classified as being non-technical, and we categorised them using a crisis resource management tool. And it's interesting, you'll see when we look, that really out of all the comments we got, 5 categories out of a potential 11 accounted for 53% of the responses. So there's a fairly strong thing going on with what people want out of their MET calls. And so, as you can see here, on the right, these are real comments. So these are comments that have been made by individuals who participated in this programme. And on the left here, which was my right, you've got the crisis resource management tool that we use. And as you can see, in this crisis resource management tool, they've grouped behaviours into themes. Okay? So what we did was we said, okay, let's allocate these comments. So it is a subjective assessment because we're applying our own bias on that, but it'd be interesting to see whether you agree with us. So basically we said, well, if someone says if they think something's been done incorrectly, and I'm concerned about a decision that's been made, I've got a responsibility to speak up. And we thought that's to communicate effectively. And then we talked about having protocols on the resource trolley and how they're there to help you because no one's got a perfect memory. Okay? And we said, well, we actually think that's about mobilising the resources that we have. So it's about knowing what resources we have and how we access them. We determined medications to actually be a technical skill, that the doctors should know, well, anyone should know, the dose of the drug that they're giving, how they want it given, in what format, and that should be clearly communicated. We talked about having a structured approach to the handover, that basically, if you don't get a good handover when you go in, you're always starting from a low base and you're really playing catch-up the whole way through. And so we said that's about communication. People said then it was really important to them to identify who the leader was. Okay? And we said, okay, that's about designating leadership. That's about knowing who's in charge and who we're all paying attention to. Use a feedback loop system to make sure that your communication is as effective as it can be. And we said that's about communication. Brief, succinct handover, that's about communication. Use all the available staff to make sure we don't miss anything. That's about distributing the workload. That's about making sure that we delegate tasks to all members of the team so that one person isn't doing everything and everybody else is watching. Because you know, that does happen sometimes, doesn't it? This is what we found. So basically, across all 11 categories, you can see the actual number of responses in each one. And you can see here there's a very clear bias to the first 5 categories, which were obviously communicating effectively, mobilising our resources, establishing role clarity, designating a leader, and calling for help early. So right, for the MER team to recognise when it was out of its depth, and it actually needed more assistance, and that was when we would upgrade to a code blue. The minute we upgrade to a code blue, we get an ICU registrar and we get an additional critical care nurse as a practitioner. So we get expert hands and we get a more experienced doctor. Now, obviously, trying to implement 11 things is too hard because you actually won't achieve anything. So what we looked at is we said, well, we're going to look at the 5 most common themes that we identified, and you can see them here. And we're going to try and work on them. We're going to build them into our program and see if we can actually make an improvement. What I want to show you now is just some of the comments that we got. And I'm sure you'll see a lot of similarity here with things that people say to you at MET calls. So they say, ISBAR, which I have to confess I hated when it first came in because I just thought it was totally ridiculous, you know. Why can't a nurse give a handover? But actually I do think it's pretty good now. Because it provides you with a structure. And actually structure's great for delivering concise, relevant information in a very quick manner. This one, if the situation becomes chaotic, it's okay to say, we need a team timeout. Everybody stop what you're doing. We need to actually regroup. And we've certainly seen that in the MET scenarios where it has all gone to custard and no one knows what's going on, and the whole team gets completely lost. And if you don't have someone then who can say that, who can say, hey, we need a team time out, it just goes from bad to worse. People think a lot of things, but they never say them. And whether that's because there's a hierarchy in the room, you know, that the intern can't tell the RMO, that the nurse can't tell the intern, whatever it is, it's real, and you see it all the time when you do simulation. This relates to, I've got to turn my page now, I'm lost. So these comments relate to mobilising your resources. And people are quite inventive, really. I was really struck by the fact that one of the RMOs didn't know the ALS algorithm or had forgotten it. He just got his phone out and Googled it. And it was like, all right, we have to do this, we have to do this, we have to do this. And being, you know, a child of the long time ago, I'm not particularly technologically savvy. You know, I thought mobile phones were actually a bloody nuisance, but in fact they're really useful. We've had RMOs that have taken them out because we need an intraosseous. We all know that it's on the trolley. We've practiced on the egg, but none of us have actually ever done it in real life. So we just upload the video. And we say, right, we've got to do this, we've got to do this, we've got to do this. Okay, so these are just comments that people make. And finally, these are comments related to establishment of role clarity, that really we need a leader, or we need somebody who is going to take the responsibility for that sort of advanced decision making. And people talk about, you know, it's actually really important to have a scribe when you're into 16 cycles of ALS, because no one can remember when did we give the adrenaline last, when did we give the amiodarone, how many shots have we had, are we on this pathway, are we on that pathway? So it goes on. People talked about making assumptions about who should do certain things, because what we found was, in fact, the person that we thought was the most experienced was actually the least experienced, but somebody else was more experienced. So it's trying to open up that communication and say, you know, we don't assume, let's try and find out. How do we find out? And the fact that the leader doesn't have to be the same person from word to go. The leader changes depending on what the need is. So what did we do with the information that we found? Okay. So the first thing was that by establishing the common themes, we said, right, which areas in our scenarios do we need to improve? And we did address the technical skills that were identified, but we also addressed the non-technical skills. So how do we make people better communicators? How do we make them more able to mobilise the resources that they have? And what we did was we made that a focus of our debriefing and communication methods and strategies, so that when we talk to people, we get them to really examine how they are communicating with one another and whether that communication is useful, neutral, or destructive. And then we also wrote some new scenarios to address issues that we didn't have, and we sort of tizzied around with the ones that we did have and actually changed their focus a bit. And eventually, it's our goal to repeat the study and see what impact we've had. And hopefully, we're going to do it in this building, which is going to be our new hospital. Thank you.